Hi, Michael. How are you doing?
Very good. Thank you for having me.
Thank you for joining us as well. Welcome everybody to the webinar. So we're ready to get started in just a minute or two. We hold these webinars. We're RSAP Vision. We're a computer vision company. We develop AI solutions for medical devices, and we try to have on these webinars various leaders, sometimes from the academia or industry in AI research. But today we have Dr. Michael Gorin, a leading professor of urology at Mount Sinai, who will give us his clinician's perspective on the potential contributions of AI for urology. It's very important for us always to understand the real clinical needs and to focus our development on meeting those needs. So we're very happy today to have Michael here with us to share some of his thoughts and perspectives on this fast developing field. You guys can see here some of the things we here at RSAP are working on, surgical planning and intra-op guidance for various urological applications. But today we're really here to hear from you, Michael, what you and your colleagues would like us and the rest of this ecosystem to build for you, and where your challenges are as a clinician, what can be of most benefit to your patients in general. So yeah, without further ado, we'll turn this over to our lecturer, and here you go. Take it away. By the way, for the audience, you can type in your questions in the questions box, and we'll be dealing with them and reading them off at the end of the lecture. So as Michael goes through his presentation, please think of any questions or comments or challenges you may have, and hopefully we can have a nice conversation around those at the end.
Thank you very much for that nice introduction. Moshe, can you just confirm for me that you're able to see my slides?
Yeah, we're good.
Okay, great. So thank you again for that nice introduction. Michael Gorin, I'm a part of the faculty of the Icahn School of Medicine here at Mount Sinai. I'm a practicing urologist. My background is in endourology with a focus on treatment of prostate cancer, benign prostatic hyperplasia, and kidney stones. When Moshe had given the introduction, he had talked about perhaps me sharing, what some of our challenges are and what some applications we'd like to see artificial intelligence. And I've actually structured the talk slightly differently, and that is to show you examples of things in artificial intelligence as it pertains to urology that I'm excited about, that I see great promise in, and hopefully these could serve as sort of the seedlings for where we'd like the field to go next. The other thing I do in the talk before we get there, though, is try to bring urologists and audience members up to speed on what exactly is artificial intelligence, and some of the details about how one, how, in a very basic sense, how artificial intelligence models are developed with computer vision applications. So artificial intelligence, so I don't think any talk on artificial intelligence starts without this. Oh, I lost my slides. Hold on one second. Sorry about that. Confirm you're able to see them?
Yep.
Okay. I don't think any talk on artificial intelligence starts without this slide, and that is basically to get through some of the jargon for those in the audience who this is relatively new to. And you've probably all heard the terms like artificial intelligence, machine learning, deep learning, neural networks, and so forth. And these are all sort of interconnected terms. Sorry, I lost my screen once again. I don't know what that's about. These are sort of interconnected terms that one should be familiar with. So artificial intelligence, this is just basically a general term for programming systems to perform tasks that usually require some degree of human intelligence. And this is really sort of the blanket term for all these other technologies that we're talking about. And artificial intelligence really first began in the 50s and 60s, and it has its roots a lot in sort of military and space applications. Next, we have machine learning, and that's the training of algorithms to solve tasks by pattern recognition, instead of specifically programming them how to solve the task. So basically, rather than the machine learning specifically how to perform the activity from start to finish, it learns sort of the patterns involved with completing the task, and then could use that skill set to solve novel problems in different ways. Deep learning is sort of a more sophisticated form of machine learning, where there are multiple algorithms, what we call neural networks, that are intertwined together in a hidden layer that then allow the computer to gain insights and to teach itself about the question or the task that it's being given, so that it can achieve the outcome. And this will make more sense in a few moments. Doesn't let me advance my slides. This is where I'm having issues. Okay, very good. All right. So, as a general concept within machine learning, it's important to realize that we sort of branch out from there in different ways that the learning could actually occur. We have what's known as unsupervised learning, supervised learning, and reinforcement learning. I think sort of supervised learning is probably the easiest to understand, because many of the things that we use currently with artificial intelligence, or many of the products that we've seen in action, have been developed in a supervised manner. And probably image classification is the easiest to understand task here. For instance, maybe you have an image of a cat. You teach the computer, over thousands of pictures. This is a cat. This is not a cat. This is a butterfly, and so forth. And then with time, it learns how to recognize and discern a cat from other animals that may be in other pictures. And the supervision part comes in because you were the one telling the computer what each image classification actually was. So I think that's the most sort of the simple case. Then there's unsupervised learning, and this is really where much of the field of machine learning and artificial intelligence is going today, and that is with either zero-shot or few-shot learning, where very limited information is given to the model by a human for it to then learn how to do the types of tasks. And I think a very good example of this would be GPT chat or GPT-4, which to some extent had supervised learning, but the vast majority of what goes on with that model is happening in an unsupervised manner. Then there's what's known as reinforcement learning, and the best way to think of that is like skill acquisition or games, where a human is interacting with the model and it's providing it with feedback as to whether or not the model got the answer correct. So what are some applications of artificial intelligence in urology? Well, the answer is that there are really innumerable applications. What I've shown here on this slide is only a handful, ones that I have come across and been particularly impressed with. And then I'll dive down into some of these examples and show you, some studies or actual clinical products that have come about as a result of it. And I'll try, where appropriate, to weave in some of my own work and own research in artificial intelligence in the field of urology. So very briefly, and then we'll dive into each one individually. Some of the applications include things like image interpretation. So either entirely replacing a radiologist or assisting a radiologist in taking a look at an image and then outputting that image result. Most commonly, we've seen this done with prostate multiparametric MRI. We all are familiar probably with the PIRADS grading system. There's a number of different algorithms which have been developed for automated PIRADS scoring of prostate MRI. We also have aiding in pathological evaluation. In this little clip here, I show an image of a prostate biopsy core where all the different cancerous glands have been segmented out and a diagnosis can be rendered. And this is either, assist the pathologist or can in times even replace the pathologist. Medical documentation, this is one that I don't think often comes to mind when thinking about where artificial intelligence fits in urology. The truth is it fits in all fields of medicine, and that is to improve our ability to document what went on with a patient and to limit a physician's workload. The picture that I'm showing here actually comes from Dragon Naturally Speaking's website. Dragon, you probably are familiar with as a company that makes voice dictation tools. They have a new product called Dragon Ambient, which actually listens to you while you speak to a patient, and then writes a clinical note based on that conversation with some supervised learning that goes on initially, or semi-supervised learning that goes on initially, but with time it learns to just listen to you and the patient's conversation and record the medical chart for you. So this is a pretty spectacular one which is coming down the pike. Then we have 3D model manufacturing. This is one of the examples I'm going to dive into a bit more, and that's using 3D models for either medical education, surgical simulation, and so forth, and how exactly artificial intelligence fits into developing these models. Image fusion, very few surgical specialties are left without some form of a fusion-based tool in the operating room or procedure suite that they use. Neurosurgery was probably the first at this. In urology, we do it all the time for prostate biopsy. So I'm going to talk about artificial intelligence there. One of the new and perhaps most exciting areas is in therapy selection and disease prognostication. And there was a recently presented a large clinical trial that demonstrates the benefits of AI in helping decide who needs androgen deprivation therapy with radiation. We're going to talk about that. Surgical skill assessment is one that's already here. There's a few companies that offer it. Surgical navigation is one that our sponsor has a particular expertise in. Image augmentation, so being able to take something that's more easily attainable, like a fluoroscopic image or an ultrasound, and then being able to augment those images so they contain three-dimensional data. That's another application. And then treatment planning, and I'm going to get to an example from Avenda Health for focal therapy planning for the treatment of prostate cancer. It's not letting me advance again. Okay, very good. So much of the applications that I talked about, with really just the exception of the medical documentation example, really relies on image classification and segmentation at the heart of what these AI models do. So I already talked about classification, and that's simply a machine learning tool being able to learn, is this a picture of a cat? Is this a picture of a dog? And so forth. Then we have what's known as semantic segmentation, and that's the ability to take all the different image components out of the image and actually find that cat and now draw an outline and a mask of it. And this is critical for applications in medical imaging because we do this across cross-sectional imaging data, what we call volume data, where we're then able to take each individually segmented image and put them together to make a three-dimensional representation of the organ or the disease process of interest. There's also object detection, so more than just being able to classify and then segment out what it's seeing, but to be able to detect it and then track it on screen. And then there's this concept of instance segmentation, where items that are of a similar class, so here you can see all different pictures of animals, it's able to actually segment out in the same image each one of those animals individually, and then potentially even track them. And so again, you have to be able to perform these basic tasks when building an artificial intelligence tool for most medical applications. So I'll start diving in just a bit more for what is actually meant by image segmentation and why I would call it in its present form a modern form of torture. So as urologists, it's very common now for us to perform transrectal ultrasound, MRI fusion prostate biopsies. And this procedure relies heavily on image segmentation. And so I present it as the example that most urologists will be most comfortable with understanding. Basically, you have a multiparametric MRI, which is done prior to a patient's biopsy. That MRI likely contains a lesion, an area within the image that suggests the presence of disease. Unfortunately, prostate biopsies by and large can't be performed inside MRI scanners, so we're reliant on real-time ultrasound to perform the biopsy. Similarly, in an unfortunate manner, ultrasound is unable to see the lesion that MRI saw. So fusion allows you to take the static MRI image and fuse it to the real-time ultrasound image so that the urologist can navigate their way to the lesion with the assistance of the system. So in order for that fusion to occur, the urologist first makes a segmentation of the multiparametric MRI, then they make a segmentation of the ultrasound, and once those 3D shapes are known of those two structures, typically an elastic registration step occurs, and that's what this checkerboard is here. You can see in the upper left and the bottom right-hand corner, that's MRI data, and the lower left and the upper right, that's ultrasound. Once those two things are fused together, then you could perform, prostate biopsy with the MRI information overlaid on top of it. And there's a number of these different fusion systems which are used by urologists. These images come to us from the Coelis Trinity system, which is my preferred method of how I do this. So let me show you just a quick video of what manual image segmentation looks like. And imagine if one wanted to train an artificial intelligence algorithm, how painful it would be to have to take hundreds of cases with dozens of images each. Now we're at thousands, if not tens of thousands of images to manually segment each image to feed into an artificial intelligence algorithm. So it's just a short video. This is me segmenting or contouring a three-dimensional ultrasound of the prostate, basically place some bounding points, then slice by slice, I go through this and I modify the contour so that it aligns perfectly with the prostate by placing different points all along the exterior of the prostate, and I do this on a slice by slice basis. And this is how it's done clinically with most products right now. On Friday, I'll do 4 or 5 biopsies, and with each case, I'll spend 5 to 10 minutes just with the ultrasound component alone performing this the segmentation task. Move on to the next slide here. So how does segmentation model training occur? And this is really meant to just be high-level basics. Well, essentially, you have a ground truth data set. You have images or volumes, and then you have segmentations. And up until recently, most of these segmentations, again, were generated in a manual fashion by some expert going through and contouring out all these structures. This data set is then fed in as both training and validation data, usually broken like 80%, 20% of images. And then one of several different neural networks could then be trained to be able to discriminate whatever the segmentation is, or whether it's an image classification task, a segmentation task, and so forth. Basically, whatever the task is, it could be trained to discern the item of interest using the combination of the training and validation data. I put here a UNet framework. That's probably the most commonly used framework for image segmentation. And then at the end of this process, you get a trained model. You could then deploy your model where then you have new unseen data. You feed that data into the model, and out pops the predicted mask or the predicted answer to the question that you're asking. And these trained models can be packaged in software, deployed on the web, built into actual medical devices, and so forth. So this is just sort of high-level basics of what goes into training and deploying an artificial intelligence model. So now, by contrast, I'll show you the same task of segmenting a prostate ultrasound, however, using a model that I trained to perform this task. So leading up to the deployment of this model, I took about 50 three-dimensional prostate ultrasound images, and I manually contoured all of them, taught a model how to do this, so now I never need to do it again. So let me show you that. So I go ahead and run the model, and then bam, the contour appears on top of the prostate. So again, this is one of the key components of how artificial intelligence is being used, because so many of the applications that I talked about earlier have a requirement to be able to detect or fuse structures within images to then be able to perform the clinical tasks that the urologist is interested in. So I've already noted some of these challenges. So the challenges with AI work that relies on segmentation, you need these exceptionally large relevant data sets. So if you have a clinical problem you're trying to solve, you need some form of data that pertains to that problem, and then you need tremendous labor and expertise to generate the ground truth segmentation data sets. And so that in many ways has been sort of the point of resistance to the development of many more tools that use artificial intelligence, simply either because we don't have the data sets or enough data to both train and validate a model, or we don't have the workforce or the expertise necessary to perform segmentation or labeling tasks as it pertains to those data. Thankfully, though, the field has been very generous towards one another, and now there are increasing numbers of available data sets that one could work with when doing artificial intelligence work. This is from a website, MedSeg AI, that I frequently use, where they keep sort of a catalog of different data sets that are available. And you can see we have, CT scans for kidney cancer with clinical data. You have the prostate X challenge, which is multiparametric MRIs, et cetera, and so forth. So lots of now freely available data. And importantly, the National Cancer Institute keeps data sets of it, and they're made publicly available for many, many different disease states, pathologies, and organ sites that one could gain access to the web as well. So given that challenge, the field is shifting towards either partially supervised learning for segmentation or image labeling tasks, or towards almost entirely unsupervised labeling or segmentation tasks. One of the big developments in the last year was the publication of a paper and release of a product known as Total Segmenter, which is used for automated image segmentation. This artificial intelligence tool was trained to be able to automatically detect and segment basically every bone in the body, and most of the major viscera, the brain, trachea, lungs, liver, kidney, spleen, bowels, and then many muscles as well. So this model again was trained up to be able to do this. So now if you're, say, starting with a task where you want to be able to identify the lung, and then within the lung find a tumor, so that you could then design maybe an intraoperative guidance tool for ablating lung tumors. Well, because now the Total Segmenter tool has been made available to us, you don't have to reinvent the wheel for being able to segment the lung. You could start with the artificial intelligence algorithm that they have developed, and they'll build off of that moving forward with your task. Hold on. And so, these are some data from the paper, which was published in an archive on what the data set was like for doing this. They basically, had several hundred CT images of all different parts of the body, and then they had humans go through and segment all these different organs. They did it in sort of this reinforcement manner, where as they would perform the segmentation task, they would sort of train a rough version of the model. Then the rough version of the model would do the initial segmentation, then the human would come in and improve it, and so forth. So they're able to sort of speed up their segmentation and labeling tasks with time. But in the end, they were able to train models against all these different organs with very, very high DICE scores, and that's essentially what these data are showing here. So then, so this is sort of semi-supervised learning, this concept of being able to take or transfer learning, where you could start with an artificial intelligence model and then sort of use that work to then build off of it for making new segmentation tools. Well, just in the last week, we saw the first example from Meta, formerly Facebook, of an artificial intelligence tool that really needs little, if any, training whatsoever to be able to do image classification and image segmentation. And that's what's known as the Segment Anything tool. And here you could see it's a prompt-based tool, so the user could place a cursor on any pixel inside a picture, and based on the prior learning that this model has done using several million images with several billion labels, it's able to automatically discern out the structure of interest. It could also do this in an automated fashion, which is what this middle image is doing here. Basically, it throws a bunch of points onto the image and says, did anything I hit look like something I've seen, I've learned about before? And then it segments it out for you. And it doesn't only just provide that one segmentation. What this third image is showing here is that sometimes the context of the point that's being placed is a little unclear. Did you mean to segment out just the jacket, the person's entire outfit, or the jacket, the outfit, and the person itself? And so it could actually provide you with a number of different labels with different probabilities that you could then work with downstream. And an important thing is that the Segment Anything data set included medical images for part of its training. And I'm going to share with you a tool that myself and my fellow Basil Kaufman have developed to help us use the Segment Anything tool as a starting point for medical image segmentation. So I believe the reason why Meta has developed this tool is because, as we know, they're called Meta now because they're all about all these different things in the metaverse and so forth. And when doing virtual reality or augmented reality, a critical task is in real time be able to gaze at different items and then have the hardware and software be able to tell you what it is that you're looking at. So this is an amazing video that a Meta employee filmed at home when they wore home an AR goggle set that incorporated the Segment Anything task. And you could see just looking all around the room, and it's finding items and telling this individual what those items are. So you can only imagine what's possible with a tool like this. So another reason I mentioned the Segment Anything tool is because it really highlights for us the amazing pace of discovery that's going on right now. The Segment Anything tool, or at least the paper that went with the tool, was published in Archive on April 5th, 2023. Within a day or so of publication of this article, myself and other people who are excited about artificial intelligence were already working with the freely available code in GitHub to work to design applications that implement it. People worked on this so fast that only a week later, another paper was published known as In-Paint Anything, Segment Anything meets image in-painting. So these are folks who did not work at Meta Facebook, and they took the SAM, what we call SAM's, the Segment Anything model, and were able to build a pretty amazing piece of software built on that backbone in just a week's time. So this is what In-Paint Anything is, not really relevant to medical applications, but just shows you the amazing power and the speed at which the field is moving. So they took the SAM tool. Again, you're able to just put a dot on anything in an image and it automatically segments it for you, which is basically where we go with this middle panel here. But then these folks already had an existing artificial intelligence tool for deleting a segmentation from an image, filling in the pixels of what's left behind, and then allowing the user to then place a new segmentation on top of it to replace what was originally in the image. So here you can see they have a dog, they segment out the dog, they delete it from the image and they replace it with a teddy bear. They remove the donut, they replace it with the camera lens. Here they remove a tugboat and they replace it with an Air Force carrier. Pretty unbelievable, also a little bit scary, in particular the aircraft carrier example. You could see how this could lead to fake news and so forth, but still at the same time, pretty amazing. So myself and Dr. Kaufman, we wanted to see if we could make use of the SAM model for automated medical image segmentation, because if we're able to perform our segmentations now in an automated fashion, this would greatly speed up some of the downstream training tasks that we want to do. Say, again, for example, we want to be able to segment the prostate, and then within the prostate, we want to find radiomic features that maybe predict the presence of prostate cancer. Well, that radiomic feature part of it, that's going to probably require all sorts of training, but segmenting the prostate, that really shouldn't. So can we use SAM to do that? So now I'll share with you this video here. So we very simply designed a tool that allows the user to take a DICOM image and load it, and then you could place, hold on one second. Then you could place points all throughout the image. Then you run the perform segmentation task. It basically runs the code that Meta provided us, and then bam, just by where the points are, it's able to pick out, you know, where the prostate is and segment it rather expertly. So the blue points are what we want included. The red points sort of represent the bounds of what we don't want included. Now in the same image set, I'll now just place a point on the bladder. So notice I didn't shut down the tool, refresh or anything. It right out of the box knows how to segment the prostate and it knows how to segment the bladder. You can imagine our radiation oncology colleagues liking having a tool like this when they're planning so they could avoid the bladder when they get prostate radiation. Here I am just seeing how well the tool works on a bony structure. And there it goes. It was able to, confidently segment out the acetabulum and the bony parts of the pelvis. So anyway, so this is I just wanted to give you guys a quick overview of really, what goes into developing artificial intelligence modules, artificial intelligence tools, what some of the bottlenecks are in terms of data, and how some of those bottlenecks really, just in the last few weeks alone, folks have started to be able to break free of to make some pretty amazing tools. So now for the rest of the talk, I'd like to go through with you just some examples of tools that have already been built. Really, I don't think any of them use this, zero shot or few shot learning techniques that I was talking about. They all relied on more traditional techniques for making traditional like it was 3 months ago, techniques for training artificial intelligence models. And I'll show you clinically what some of these tools have been able to do. So the first I'll start with is image interpretation. Those of you who are on the call who are already familiar with me know that a big area of my research over the years has been in PSMA-targeted PET imaging of prostate cancer. I was involved with many of the clinical trials that led to the FDA approval of DCF-PyL, which is now known as PYLARIFY from Lantheus Medical Imaging. This imaging agent is for PET imaging. It binds to PSMA, which is constitutively expressed at very high levels on prostate cancer cells. And so it allows us to, for the first time, be able to visualize prostate cancer at impossibly small lesions that we couldn't see with CT and MRI previously. Here's just an example image of what that looks like. Here we have the CT scan with the PET images superimposed on it. Certainly, I don't need these red arrows to show you the areas of disease, but I do anyway for those unfamiliar. This is what's known as a maximal intensity projection, where it's sort of a 2D projection of 3D data with arrows pointed to all the sites of disease. And while looking at this image, sure, it looks like, it would take you 5 minutes to be able to look at these images and be able to determine, a patient's volume of disease, where their sites of disease are. But this was a case that was, very easy. Patient had a lot of disease. Many of the patients who undergo PSMA PET scans are doing so for what we call biochemical recurrence, where they've been treated for their prostate cancer. Their disease was thought to be cured, and now only on the basis of a very sensitive PSA blood test do we know the prostate cancer is back again. In the past, we would subject these patients to bone scan, MRI, CT scan, and we can never find any sites of disease. Now, PET scan is able to help us do that. However, in such a low volume disease state, it becomes really, really challenging to find these sites of disease. So Lantheus has come up with a product which is already clinically available, it's FDA approved, known as PYLARIFY AI. And what they've done is they've basically trained an artificial intelligence model with scans that were previously read by humans as the ground truth data set for where sites of prostate cancer are located, and developed a tool where you could now take a PET CT scan of a patient with prostate cancer that the tool has never seen before, and it could then read it just like a human can and help you identify sites of disease. There are some other really cool features of the software. For instance, it determines for you what's known as the PSI index, which is kind of the degree, the number of lesions and the degree of uptake, and this is thought to perhaps be predictive of prognosis and response to therapy and so forth. A bit outside the scope of this talk, but what we're really talking about here is lesion detection. It keeps coming back to that same concept. So Jeremy Calais, who's a very well-known nuclear medicine physician radiologist at UCLA, performed a secondary analysis of the Condor trial, which was a trial I was involved with, that developed PSMA PET imaging for biochemical recurrence. And what they did is they took humans and had them read the scans, and they compared those manual reads to automated reads using the PYLARIFY AI tool. And they looked to see, inter-reader variability, intra-reader variability, the cancer detection efficiency, and very importantly, and this is the first data I'll share with you, how much faster the tool could do it than the humans. So here are those data for how fast a human can now do it using the artificial intelligence tool. It took the readers a median of 1.4 minutes with an interquartile range of 2.1 minutes to read a PET scan. Manual reading was estimated to be at roughly 15 minutes for the radiologists who were involved in the Condor study. Think about that for a moment. Almost a 14-fold improvement in the in the output that a radiologist can do in one day because of now using this tool. And you could see this was preserved across the 3 readers that participated in the study. Intra-reader comparisons, these are the kappa statistics for T stage, N stage, M stage, and then overall TNM staging for the three readers. And you could see, reasonably high kappa statistics showing good concordance between, of the 3 different readers for these different parameters. They then went ahead and pooled the readers and compared the reading relative to the manual reads, and they found that that the PYLARIFY AI was able to perform, was more reproducible than manual reads were with consistently higher kappa statistics. So then in terms of cancer detection, the cancer detection rates by the PYLARIFY AI tool was very comparable to the manual reading of the scans. And so, basically what they show is that it's really non-inferior, but performs 14 times faster. Interestingly, one of the readers actually had a statistically significant improvement in their cancer detection rates using the tool. Small numbers, only 3 readers, but is it possible that 30% of readers will even get better when they use this tool? And interestingly, sort of consistent with what I was saying earlier about why we need a tool in biochemical recurrence, they found that the greatest gains were made by the tool in patients with very low PSA levels. So these are the hardest scans to read, and those are the ones that the tool is potentially most useful. And what's great about this tool is you get this beautiful report at the end of it as a clinician downstream of the radiologist, where it tells you the patient's TNM stage. They outline for me where each one of the lesions are that the patient has, the SUV values. It shows me a picture here with the segmentations of where those different SUV values appear in the patient, and also the amount of SUV uptake that each lesion has. So really, really clinically useful information already at our fingertips using AI. Moshe, at this point, maybe is there a question or two on what I've shown, and then we'll go to more applications? Just not sure how you want to structure it.
One question up until now. So the question is, do you think that these foundation models will replace supervised learning for medical applications? I mean, for regulatory approved medical applications anytime soon? Like, what is the hurdle for that? I think the reason is, of course, that they're trained mostly on non-medical data. So where's the gap?
But they serve as the starting point, right? The effort to supervise or semi-supervise a model is so much less now that you could start with really close segmentations to begin with. I have a feeling that those models will be fine-tuned in the future with increasing medical data, where we never need to supervise the task. And I'm sure that probably next week someone will publish that. But at least for this talk today, on April 19th, 2023, it seems like it's going to serve as a starting point. I don't know, Moshe, you're an expert in this too. What are your thoughts?
Yeah, so like an annotation tool, but on steroids, right? So instead of spending a month creating your starting point model, then you get it for free from day one. Then you can just move much faster to get the medical grade model.
Yep. All right, so unless there are other relevant questions, maybe I'll move on to 3D model manufacturing. Okay, so the next one will be 3D model manufacturing. So why 3D models? Well, it's felt that if a clinician, a surgeon had access to a patient-specific model that shows their anatomy and their pathology, that it would improve patient care. Firstly, it'll improve patient consent and communication. I can't tell you the number of times that I'm sitting in a room with a patient and I'm scribbling on pieces of paper these very crude drawings of what their disease state looks like, what their anatomy looks like, and the surgery I'm going to do. And for the life of them, the patients cannot understand what I'm drawing. Probably most doctors outside of my specialty can't even understand what I'm drawing. So if you have a model, you could really do a better job explaining this to patients, okay? It enables pre-surgical practice and simulation. So maybe it's a complex task that you're gonna do, and you don't want it to be the first time on that patient's anatomy. So ahead of the procedure, you could actually take the model and practice something like robotic or endoscopic surgery using it. There are some specialties in medicine where we use patient-specific devices. We don't do this yet in urology, but this is very common in orthopedics, neurosurgery, dentistry, where different implants are derived from, and they're patient-specific, and these require medical models be made. Potentially could increase insight into the patient's pathology. I'm not really certain yet how that's possible, as it's not sort of as clear to me as these other ones. Facilitate multidisciplinary team discussion, sure, I could understand that. If a bunch of us are around a table prior to a case and we have the patient's anatomy in front of us, we could discuss it. And I think from a dollars and cents standpoint, where they're trying to really market this, is it could potentially reduce OR time if you have that model in front of you and come to the OR practice, with your colleagues, understanding what's going on as well. So there's no shortage of papers on examples of folks 3D printing different models for preoperative planning purposes. These are just some images from a paper that was published in the Journal of Endourology, where this group went ahead and made different models of the kidney with tumors and vasculature to basically get acquainted with the partial nephrectomy procedure that they'd be performing, with a particular focus on approaching the tumor and ensuring that they have a negative margin when they remove it. And here's an example of what one of those plastic tumors looked like relative to the actual tumor after it's been cut out. And what this group did is they went ahead and they surveyed the different urologists who had access to these models, and and asked them different domain questions about how much did it help them, how much did they like it, do they feel it improved their ability to be able to see the vascular tree, et cetera, and so forth. And overall, the surgeons really liked having these models. They felt that they had a realistic resemblance with a 9 out of 10. They really liked that when they were cutting into the tumor itself, that the use of the model ahead of time, it sort of oriented them to the position of the tumor and the depth that they needed to cut at. And I think you get sort of the sense here for what the surgeons felt in using these models. So there's actually now an industry that has cropped up, giving surgeons access to 3D printed specific models. So you don't actually have to produce them at home in your garage anymore, like many of us were doing in the early days of this. There's this one company, Axial 3D, where they could, you basically upload DICOM files. They'll do 3D visualizations for you. They'll print the models, or they'll provide you with print ready files, and you can print them yourself. And look at this here, segmentation as a service. This is really what you're paying for, all the labor that it goes into a human going through and segmenting each one of these models. This is from another paper, just sort of showing what that means, how it all comes together. Basically, you have the CT scan, you segment it out, create a 3D volume, and then you use a 3D printer to recreate it. In this paper, published in the Canadian Journal of Urology, the author wrote, segmentation was performed by manually denoting the borders of the desired structures slice by slice through the series, which takes around 2 hours for the technician to perform. Imagine now doing this with the artificial intelligence tools that segment the organs for us, like SAM, which I showed you. Now you could imagine how making a 3D model is basically a painless task. All you have to do is wait for the printer to print it. So shaving off significant time, making these 3D models now ever more available to urologists in their clinical care. So next I'll move on to the application of therapy selection and prognostication. And I'm going to share with you what I think is absolutely one of the most exciting studies I have seen in maybe the last 5 years, if not more. And that was an abstract, it hasn't even been published yet, by Dr. Daniel Spratt, who's the chair of radiation oncology at Case Western Reserve. They took patients who were enrolled in these RTOG radiation oncology trials. Patients were randomized to either receive standard radiation therapy or radiation therapy with androgen deprivation. And they had all the clinical data for the patients who participated in these various trials. But in addition to that, they had scanned glass slides of the patient's biopsy pathology. And so then they were able to feed into a neural network patient data, the digital pathology results, and some clinical data beyond just simple demographics. And they were able to build an artificial intelligence-based model that was able to then segregate patients into groups of, did they do, did they develop metastatic disease or die from prostate cancer? Was the tool able to predict it? And then what this does is then informs downstream whether or not you should place a patient on androgen deprivation therapy. So for instance, in these trials, they know what a patient who received radiation alone, didn't receive androgen deprivation therapy, and did poorly now looks like using this artificial intelligence tool. And that's someone who now they can make the recommendation for receiving that therapeutic going forward and partner in combination with the radiation therapy. 1 second. Hold on. I'm having an issue with the power to my keyboard. Okay. So, the AI aids in determining who will benefit from ADT. These are what the different features were and their relative importance as they made it into the final model. You could see all these different features from the digital histopathology, features that we in our minds as humans can't even possibly discern because they're included in the inner hidden layers of the convolutional neural network, were pulled out and became weighted and incorporated into a score that helped make these predictions. So what they then did is they bin patients into high-risk biomarker group or biomarker positive, biomarker negative group, and then they looked to see what was the absolute benefit of androgen deprivation therapy in comparing biomarker positive and negative patients, and they see a 70% reduction in the event of distant metastasis with the addition of androgen deprivation therapy with incorporation of that biomarker data. They find the same thing with prostate cancer specific mortality. They did not see it, although it was close to significant overall survival as well. So really unbelievable. So what's the computer vision segmentation task here? Well, basically taking those histopathology slides, being able to segment them out and detect features within them that then can be combined with clinical parameters to make this sort of clinical prediction. Next up, I'll talk about surgical skills assessment. There's been a lot of work done in this arena, most of it being done at the University of Southern California by Andrew Hung and Dr. Gill, who's the chairman there, taking robotic surgical data and looking to see, can it predict different patient outcomes so that you could basically, score a surgeon and how good of a job they're doing at surgery, or perhaps be able to inform a patient of the likelihood of an outcome may be achieved based on the surgery that you just performed on them. So in this first study, they weren't using images, but rather just raw data that came back from the robotic surgical platform. And they built a model looking to see if whether or not any of those features that came back from the robot, either alone or in combination, could predict whether or not patients achieved early urinary incontinence.
Michael, your sound's, maybe you're back.
Are you there?
Yeah, your sound cut off for just a second, and your camera feed, but yeah, I think we're okay with the sound now.
Okay, all right, got it. Good. And so they were able to then look at whether or not those parameters that they got feedback from on the console was then able to predict early urinary incontinence following robotic radical prostatectomy. And they also control for the age of the surgeon, the patient age, as well as the level of expertise of the surgeon to look to see, if independent of those features, whether or not the tool could be used to predict this outcome. So these are the measured parameters, And again, these are really like mechanical parameters, ones that the robot gives back. So it's like, total time that you were on the console, path length of all three of your instruments, the number of radians of rotation each wrist saw during the procedure or during a certain step of the procedure. How much did you use clutch? How much did you use the third arm? How much energy did you use? All these different parameters. The top 5 parameters are certainly ones that, I don't think I would have necessarily predicted, but they came out as significant and were ultimately incorporated into a model. Things like, how long the third arm was not moving during one particular part of the surgery, how much right instrument articulation was occurring during the vesicourethral anastomosis, either anteriorly or posteriorly, and total time to complete the surgery. So anyway, features like this, they assign different weights to based on their relative import at predicting the outcome. Somehow the data slide got removed. I'm sorry about that. Well, anyway, suffice it to say that they saw about a 10% improvement in being able to bin patients as early as to be able to predict which patients were going to be continent or not be continent at the 3-month time point with the information learned from their model. So, pretty good. Definitely good as a first pass at this. But just recently, Dr. Hung's group published a paper in Nature Biomedical Engineering. And this paper is just, it's mind-blowing to think that Dr. Hung, who is a urologist, was able to put together all this work with engineers at USC. But basically, they've redone those types of experiments I just explained to you. But now they're doing it with the actual robotic video feeds. So they've trained up models to be able to look at a surgical video and figure out first what part of the operation is the surgeon on. Is it dissection or suturing? Then to pull out individual instrument gestures that are occurring during that surgical step. Are they moving? Are they hooking? Are they clipping? Are they peeling, cutting, and so forth? Okay. And then looking to judge whether or not during that actual task, are they showing high skill or low skill? They're also able to look at other components of the operation, like camera removal, camera inspection, camera insertion, and pull that information out of the video, and then also measure how much time was spent on, that type of task, and see if that corresponds with patient outcomes. So for each frame of the video, relative to what portion of the operation they were in and what tasks they were doing at that given time in the video, they were then able to assign, what the skill was against the ground truth, assign importance to these relative tasks. And doing this, they were able to find that controlling for surgeon caseload and patient age, early continence recovery was 1.3, so 30% more likely when the surgeon was deemed as high skill by the artificial intelligence algorithm. So almost like a surgeon's scorecard, right? I only want a surgeon who's operating on me who's deemed high skill by this algorithm. Where is this going to take us in the future? Very interesting. This relationship was only strengthened when all measure skills were considered. This is what skill do they account for here? This was simply only the skill of performing the vesicourethral anastomosis. When you look at the entire video for all different tasks, it gets even better. So really unbelievable paper. I'm excited to see what Dr. Hung has for us next and the group at USC.
Yeah, it's quite exciting and taking this to the next level. Not only segmenting the surgery into stages to support a system, but actually correlating that with patient outcomes. That's quite impressive.
Yeah. Now, I haven't seen a clinical product yet. There are other clinical products that are available. Say, I'm a surgeon, I want to be able to review my own videos, but I don't want to take the time to break it into clips. There are services that you could pay for where you upload your video, then they use AI to parse out the clips for you, so you could then sort of have like an index to click on to go watch your parts of your videos. There's also a service that's available, that's currently available, where it will kind of tell you what step of the operation is occurring. It doesn't grade anything, but it tells you this is the vesicourethral anastomosis, this is the bowel resection, and so forth. So, this is the next stage, I think, of commercial implementation. So the final application I want to share with you before getting to my conclusions and then opening up to discussion is treatment planning. And I wish to share with you an example from my friends at Avenda Health. This is an amazing company that comes out of work that was done, really led by Lenny Marks at UCLA in the Department of Urology there, where they have taken their experience and information learned from prostate MRI and prostate biopsies that were performed to build an artificial intelligence model that's able to take as input biopsy core results from a user, and then to be able to draw a heat map and predict the likelihood of where prostate cancer is found in this gland. And this is important because when you perform a biopsy of a prostate, you're only sampling like 1/1000th of the gland, even when you do 12 plus cores. We know that multiparametric MRI, which oftentimes guides biopsy, has a negative predictive value that falls short by about 15% or so. So there's lots of opportunity to miss cancer in the gland. And as the field becomes increasingly excited about things like subtotal prostate ablation or subtotal prostate surgery, where we're only treating a portion of the gland, we have to have a really high degree of confidence that based on our imperfect biopsy result, that when we deliver therapy, we're going to treat the entire area of the gland. And that's what Avenda Health has done with their Unfold AI product, which is available. You can go to their website to learn more about it. And they boast on their site that they have greater than 98% sensitivity for finding the extent of cancer in patients with intermediate risk disease. And I was just at a conference this weekend where I had a chance to play with this tool, and I would certainly believe it. They've also done some other work that hasn't been published, but my understanding is going to be presented at the AUA by Wayne Brisbane, where they're also able to look at, the tumor margins. It increases the ability for the clinician to do this by 20%. And Wayne's work specifically looks at whether or not you could use this tool to predict the presence of extraprostatic extension. So even if you're not using this tool for planning focal gland ablation, you could use that information now for whole gland treatments like robotic prostatectomy or radiation therapy and so forth. So a lot of information to be learned from this tool and potentially used clinically. There actually, to the best of my knowledge, has not been a publication on all the artificial intelligence work that went into the development of this tool, but that group previously, when the leadership was at UCLA before they moved and formed this company, had published on similar types of tools that use more rudimentary artificial intelligence based tools. Like here, they basically use a cart branching, decision tree analysis to arrive at similar bits of information. And again, they're taking in all different features: positive core locations, negative core locations, where the cancer is visible on MRI, what the grades of the cancer were, and they run it through this decision tree analysis, and then are able to predict whether or not prostate cancer is going to be bilateral, unilateral, and so forth. And what they found is that, using the decision tree, they're able to half the human error rate when they use this tool. And then they've only taken that to the next level using things like convolutional neural networks in their current product. And I'm excited to see the publication that they eventually come out with that sort of, opens up the black box on how they did this, because it's really amazing. And these are just some of the AUC and sensitivity PPV values from that same study. So in conclusion, AI, machine learning, deep learning, all these concepts have the potential to impact patient care in innumerable ways. And I've just shared with you today the ones that I have picked out in urology. There's probably another 100 in urology that I haven't picked out, and innumerable ones throughout the field of medicine that I'm not even aware of. But specifically within the field of urology, at least in my view, this includes important tasks like image interpretation. I shared with you the Polarify AI. There's also other tools for grading the PIRAD scoring system on prostate MRI. Segmentation and fusion, I shared with you the example of prostate biopsy. Imagine how much faster we could perform that procedure if we just had AI to help us do our contouring. Clinical documentation, an example I didn't show you, but one that I'm very, very excited about, is using AI to just listen to our conversation and document what went on during a visit. Disease prognostication, I showed you the work from Dan Spratt. Surgical case review and outcomes prediction. 3D model construction for a variety of applications, and then just the last application of treatment planning. The majority of AI tools in clinical use require some form of image classification and segmentation, basically computer vision. And I think that, at this point, this is basic knowledge for a urologist to understand what these classification, the basic of a classification task, what segmentation is, kind of that flow chart that I showed of how models come together and are validated. And then, there was a question earlier, which is really what I say here in this last point, that I really think that zero and few shot learning models will likely form the foundation on which new AI tools are built, and it's going to tremendously accelerate the work that we're seeing. And I expect if there's 1,000 applications today, there being 5,000 applications next month. So again, I wanted to thank the crew at RSIP Vision for inviting me to give today's talk. Visit their website. You can see all sorts of amazing computer vision technologies that they've developed, many of which have applications in urology and other areas of medicine, and sort of are close cousins of the sort of work that I've shown you here today.
Thank you so much, Dr. Gorin. Thanks, great picture. So we have a bunch of questions here, but we've got very little time, actually negative amount of time. So I'm going to just choose one that's taking a slightly different angle, and I'm really curious about hearing your thoughts on this one. So there's a question from Austin, Dr. Gordon, RSIP. Thanks very much for your time and expertise. As engineers, we're often looking for ways to connect with clinicians interested in exploring these areas. Any suggestions on the best way for engineers to go about finding and connecting with clinicians in the field?
Yeah, so that's a great question. So I'll tell you about a very successful program that I saw when I was formerly at Johns Hopkins. The undergraduate engineering students, when they would go through, I don't know exactly what BME course it was, but part of that course was to come to the ORs and just pop in and out of different surgeons' ORs to see what's going on, what tools are surgeons using, whether they're urologists, spinal surgeons, and so forth, so that then they could meet clinicians, understand what the problems are, and then work collaboratively with them to come up with projects for their coursework. So I think that's a good way, you can't just obviously show up to the OR, but get in touch with administrators in different clinical departments and ask, how can you just come to the clinic and meet some of these clinicians, see what they're doing to come up with ideas together?
Yeah, there's nothing better than firsthand, viewing things firsthand. Yeah, I think Shmuley can also attest to that very much.
Definitely. Yeah, and by the way, conferences, right? So we have the AUA next week in Chicago. Probably a lot of industry will be there. That's always a good opportunity to meet physicians, and people in the industry.
Mm-hmm. Yeah, and if you want to hear more about what RSIP is doing, I'm going to be at the AUA, so is Shmulek and Moshe, and we'd be happy to sit down, and talk about people's interests in the field and ways that we could potentially help them or collaborate with them towards building actual tangible medical devices. Okay, that's
right. Thank you very much, Dr. Gordon, and thank you very much for everybody who stayed on even a few minutes past our time. So yeah, have a great rest of your day, and we'll see you all at the next webinar. Have a good day.
Thank you.
Thanks.